Yeah.
So it's just gone 1 o'clock. We have a fairly jam-packed session ahead of us, so I'm not going to take up your time. Nobody has come here to hear me talk. I am the current clinical lead of the Irish Molecular Tumour Board, and it is my great honour to have 4 of the foremost experts in their specialties here today to give us what will be an absolute whistle-top tour de force across 4 cancer types, looking back from 2000 to 2025 and how precision oncology has really changed and transformed the cancer care that we deliver. First up, I would like to introduce Hazel O'Sullivan. She's a thoracic oncology specialist at Cork University Hospital. That will very quickly move on to Dr. Caitriona Goggin, who's our medical oncologist at University Hospital Waterford. And then we'll invite Professor Grainne O'Kane to speak, who's in St. Vincent's University Hospital, to speak on hepatobiliary cancers. And finally, last but by no means least, the indomitable Professor Michaela Higgins will give us a talk on breast cancer. So I'm going, any questions and answers, could you please add them to the Q&A? We'll try and answer some of them live because we don't have a huge amount of free time, but we will answer them at the end of the 4 sessions. We have almost 200 people expected to register, so looking forward to the talks. And you can take it away, Dr. O'Sullivan.
Thanks, William Dervla. So summarising the last 25 years of precision oncology in lung cancer in 15 minutes is a challenge. We're going to try here my disclosures. So first I'm going to speak about oncogene-addicted non-small cell lung cancer and use EGFR mutant disease as a case example. Then I'll touch on non-oncogene-addicted lung cancer and biomarker testing. So 25 years ago, the treatment landscape for non-small cell lung cancer was very different. We had a one-size-fits-all approach, as evidenced very well from these Kaplan-Meier curves from a trial of 1,200 patients, where no matter what first-line treatment option you gave them, the outcome was very similar, with a median progression-free survival of just 3.5 months in the first-line setting and an overall survival of just over 6 months. But today we have multiple treatment options based on patients' genomic profiles and PD-L1 scores, with some patients having prolonged responses and median overall survival measured in years, in particular for oncogene-addicted non-small cell lung cancer. Gefitinib was the first targeted therapy approved for non-small cell lung cancer, and this was based on the IDEAL studies. IDEAL 2 was ran in the US and IDEAL 1 was ran in Japan and Europe. This was a study of gefitinib, which is an EGFR tyrosine kinase inhibitor, and at the time it was known that EGFR was expressed in lung cancer disease or lung cancer patients. And the IDEAL 2 study randomized patients to 250 milligrams of gefitinib or the higher dose of 500 milligrams. And they found that the response rates were about 9 to 12% with a median overall survival of 6 months. So this was actually excellent in patients with pre-treated third-line non-small cell lung cancer. And this led to gefitinib being approved as a third-line treatment by the FDA, regardless of a biomarker. But they did note that there were higher responses in women, higher responses in never smokers, and in the Asian population. And you can see in the IDEAL 1 study that the response rate was higher, up to 19%. So here we are in 2003 with a targeted therapy approved with no associated biomarker, and so begins the story of EGFR. 1 year later, Lynch et al. Published their findings where they sequenced the tumour of patients who had responded to gefitinib and those who hadn't responded, and they sequenced the EGFR gene and noted that there was a high incidence of mutations in the tyrosine kinase domain. Particularly, they saw EGFR exon 19 deletions and exon 21 L858R alterations in those who responded to gefitinib. They did not find these mutations in those who didn't respond to gefitinib. While the IDEAL study was undergoing, the IPAS study was being designed. This was a study in Asia where they enriched the population with never smokers or light ex-smokers because they knew that these patients were more likely to respond to gefitinib. And in the intention to treat group, they compared the first-line gefitinib versus carbotaxol, and the response rate was higher with improved progression-free survival in those who were treated with gefitinib front line. And then they then looked for, in a post hoc analysis, having the Lynch et al. Data, that those who had an EGFR mutation had a much higher response rate of 71%, and those who didn't have an EGFR mutation did not respond to gefitinib. So later in 2013, gefitinib was the first approved targeted therapy with an associated biomarker for EGFR mutant non-small cell lung cancer, with an associated PCR assay that looked for exon 19 deletions and LA5-IR mutations. And now we know that there's a spectrum of EGFR mutations in the tyrosine kinase domain, and EGFR mutant disease accounts for 10 to 20% of non-small cell lung cancer patients' adenocarcinomas in Europe, and up to 50% of disease in Asia. And there's a spectrum of mutations in EGFR, with classic mutations, the exon 19 deletions and LA5-IR accounting for up to 80% of mutations, exon 20 insertions approximately 10%, and atypical or uncommon mutations approximately 10%. And these less common mutations have poorer outcomes. These patients do not respond well to a first, second, or third generation tyrosine kinase inhibitors compared to the classical mutations. And since the discovery of EGFR as a target alteration in 2004, we now have had unprecedented progress in identifying molecular alterations that we can target in non-small cell lung cancer, with up to about 60% of adenocarcinomas having a target alteration. And in Ireland, we know from Rachel Keogh's data and with Drushka Naidu published in the J2OCOR last year, that 30% of patients in Ireland have a KRAS mutant disease, with 8.8% of non-small cell lung cancer patients having EGFR mutant disease. So in 2003, gefitinib was the first approved target therapy, and now we have multiple targets and associated therapies. However, not all of these agents are available in Ireland. We still do not have a KRAS G12C inhibitor, which I'll touch on, a RET inhibitor, or HER2 targeted therapy in Ireland, despite it being approved by the EMA as well. Despite the excellent responses we see with targeted therapy in lung cancer, resistance does occur. This is from the FLORA study, which showed that first-line osimertinib, which is a third-generation tyrosine kinase inhibitor, has a high objective response rate of 80%. This is a really satisfying disease to treat. A patient might be very unwell with their disease, and within days of starting osimertinib, they can feel better. But the progression-free survival is only 18 months, and the median survival is approximately 3 years with using osimertinib in the first-line setting. So how does resistance occur? It can be on targets such as the EGFR C797S, or off targets such as MET amplification or fusions, or the disease can change to small cell carcinoma or squamous cell carcinoma. But we can overcome this resistance. So as I mentioned, MET amplification is a resistance mechanism to first-line osimertinib, and it occurs in approximately 7 to 15% of patients. The INSIGHT-2 study showed that adding another tyrosine kinase inhibitor on top of osimertinib is safe and effective. They found in MET amplified disease, if you added tepotinib, patients had an objective response rate of approximately 50%. And this is a potential chemotherapy sparing option for patients who progress on first-line targeted therapy. We now have new drugs as well to potentially overcome this resistance. Antimab is an EGFR MET bispecific antibody, so targeting both EGFR and MET. And if this is combined with a third-generation tyrosine kinase inhibitor, lazertinib, it has better prognosis compared to osimertinib alone. However, it has associated financial and time toxicity as well as drug toxicity. This is a drug given intravenously, so it would really affect the patient's quality of life if they come to the day ward a lot more often, but a subcutaneous option is coming available. This combination is not currently available in Ireland, but is approved by the EMA. So this landscape of treatment options for EGFR mutant disease is changing all the time. As I mentioned, KRAS mutant disease is quite common in Ireland, representing about 30% of our non-small cell lung cancer patients. And previously it was thought that KRAS was undruggable. However, in recent years, we've had KRAS G12C inhibitors available, but the results haven't been as impressive as they have in other classical oncogene-addicted non-small cell lung cancer. This is data from the CodeBreak 200 that showed that using sotorasib in the second-line setting versus docetaxel had an improved progression-free survival of just a month and didn't have a statistically significant overall survival benefit. However, response rates are higher, and this again is the tablet, which is a chemotherapy sparing option. It's approved in the States, the United Kingdom, and Europe, but is not available in Ireland. And the standard of care currently for KRAS mutant disease is immunotherapy plus or minus chemotherapy based on PD-L1 score. However, KRAS inhibitors are moving into the frontline setting, and we have the Crystal 7 trial opening in Ireland, which investigates adagrasib with pembrolizumab. So maybe using KRAS inhibitors in immunotherapy would be more effective for our patients. So we await this. And it's important not to know just the oncogenic driver in lung cancer, but also the co-mutations. In EGFR mutant disease, if there's also a TP53 mutation, these patients have poorer outcomes. And in KRAS G12C disease, if these patients have a KEAP1 mutation, they also have poorer outcomes. So it's important to know the landscape of genomic mutations accompanying the driver mutation. And targeted therapy is also moving earlier into the disease. The ADORA study demonstrated that EGFR mutant classical mutations in non-small cell lung cancer, if you use adjuvant osimertinib for 3 years, it has improved survival versus placebo. And in ALK mutated or ALK fusion non-small cell lung cancer, the use of adjuvant alectinib improved disease-free survival, and overall survival is awaited. For our non-oncogene addicted non-small cell lung cancer, really PD-L1 is the only biomarker that we use at the moment to guide treatment. PD-L1 is assessed using the tumor proportion score, and it's continuous variable, with 30% of patients having PD-L1 high disease, so that's a PD-1 tumor proportion score over 50%. But PD-L1 can be heterogeneous, with biopsies of different tumors of the same patient having different scores. And the higher the PD-L1 score, the better the benefit from immune checkpoint inhibitors. And currently we use PD-L1 to guide the use of immunotherapy in the advanced disease, stage 3 disease, the adjuvant setting and neoadjuvant setting for non-oncogene addicted non-small cell lung cancer. We also use patient clinical factors such as their smoking status and their comorbidities to decide the use of chemotherapy with immunotherapy or immunotherapy alone. And there are targets beyond PD-1, PD-L1 which are under investigation. Anti-TIGIT studies so far have been not very impressive, but we have more the different anti-TIGIT agents under investigation. There's also anti-LAG3 and trials investigating anti-TIGIT and anti-LAG agents, as well as bispecific antibodies, are under investigation, including trials opening in Ireland soon. So we hope that having additional biomarkers and the use of synergy of immunotherapy agents will have better outcomes for non-oncogene addicted non-small cell lung cancer patients ultimately. In terms of biomarker testing, I've demonstrated that's really important to know the PD-L1 score as well as the molecular profile of tumors, and it's important that our centres are doing reflex testing, which is something that we have available in CUH. So based on the histology of the patient's tumor, the use of which biomarkers are assessed then. But we now have broad-based next generation sequencing on all our patients, regardless of the stage. And this is very important, as the diagnostic pathway to lung cancer for lung cancer patients can be quite long, and the need for multiple biopsies, particularly patients who have difficult disease to access. And this is where ctDNA or liquid biopsies can be helpful. And we know that using ctDNA upfront can decrease the time to treatment in patients with lung cancer, in particularly in centres that find it difficult to access biopsies for patients. But of course, tissue is always the issue, in that we need tissue to decide on the histological subtype of the cancer. And the presence of ctDNA at diagnosis is prognostic. This is data from 500 patients from the Empower 150 study, and those who had ctDNA present at baseline have a poorer outcome. But if you clear your ctDNA, this is prognostic. So for the FLORA study, patients who cleared their EGFR mutation present in their ctDNA at 3 weeks and 6 weeks had better outcomes compared to those who didn't. This is not something that we do as standard of care at the moment, but will be something that we might use in future. And of course, ctDNA is very helpful in our oncogene addicted non-small cell lung cancer. Using ctDNA liquid biopsies at progression instead of tissue biopsies is better for our patients, and can also detect target resistance mutations that we can treat. And minimal residual disease is the molecular evidence of cancer after curative treatment. This has been shown to be prognostic but not predictive in non-small cell lung cancer. In the Empower 010 study, that showed that atezolizumab improved disease-free survival. Even if you were ctDNA negative, atezolizumab improved survival. So ctDNA is prognostic, but not sufficiently sensitive at the moment to de-escalate decisions for our patients. And this will change in the future, likely when we have more sensitive assays. So for the next 25 years of precision oncology and lung cancer, I predict that we'll have broad reflex genomic testing, and we'll know our patients' co-mutations at baseline as well as their driver mutations. And the presence of co-mutations will guide the treatment escalation and de-escalation for our patients. We'll also have better understanding of resistance mechanisms. We'll have synergistic immunotherapy options beyond the PD-1, PD-L1 axis, and we'll have more sensitive ctDNA assays and use ctDNA throughout the patient's journey to guide treatment in early and advanced disease. We'll have vaccine therapies, hopefully, and there's a vaccine trial opening in Ireland. And of course, picking up lung cancer earlier is better, and we do not have lung cancer available in Ireland, which I hope we will have soon. Lung cancer screening available in Ireland for our patients. And we will likely be incorporating artificial intelligence and liquid biopsies into screening for our patients in the future as well. So thank you for your attention. I'm happy to take any questions.
Thank you so much, Hazel. We're going to take questions in the Q&A box. So please pop your questions in. Hazel is on standby to answer them if she can. And I'd like to introduce our next speaker, Dr. Caitriona Goggin. Caitriona, are you on mute?
Sorry about that.
Excellent. Can you throw up a presentation mode there?
Yeah. You can see all there?
No, just the slides. We can't see the presentation mode. I'd say that's on a different share view. Okay.
Sorry about that. 1 second. Sorry about this.
It's okay.
You can see there now.
Excellent.
Okay.
Thank you.
Okay, sorry about that first hurdle, and thanks very much. I've no relevant disclosures. So as a brief introduction, we know that sarcomas really are families of rare tumours with approximately 100 subtypes, and new subtypes being defined and refined. But it's important to point out the reality that the landscape or treatment landscape for most patients affected by sarcoma has not changed substantially in the past 25 years. And in medical oncology, we still are very dependent on conventional chemotherapy. What has changed is the focus on subtype-driven trials. We know that each subtype has its own morphology, molecular and clinical characteristics, and different sensitivity to systemic treatment. And it's the rare nature and molecular diversity that makes precision oncology both challenging and incredibly vital in sarcoma. So in this talk, I'll focus mostly on next generation sequencing and genomic profiling in sarcomas, where it has already played a major role in informing a precise diagnosis for patients, where it's going in terms of informing personalised treatment strategies. And we'll talk about some specific sarcoma subtypes where it has already resulted in expansion of treatment options. So we can broadly categorize molecular types of bone and soft tissue sarcomas into 3 groups. Those without known or typical specific molecular alterations, such as undifferentiated pleomorphic sarcoma, were very much based on the morphologic assessment by the pathologist. Those with recognized recurring molecular changes and gene fusions, amplifications, such as Ewing sarcoma, and those with very complex genetics and karyotypes, loss of tumor suppressor genes, such as malignant peripheral nerve sheath tumors. This slide shows recently described genetic alterations within different sarcoma groups, and we can really see how the biology and understanding of these tumors is being redefined, and sequencing is really expanding our understanding of the classification of sarcoma. Diagnosis is possible without sequencing most of the time, but for a percentage of patients, even with expert sarcoma pathology review, molecular data integrated with morphology is needed to confirm the correct diagnosis and advise the clinician on the appropriate treatment protocol. A targeted panel in some circumstances is all that's required in this case, as a number of sarcomas have pathognomonic genomic signatures, such as those in Ewing's, synovial sarcoma, SFT, and low-grade endometrial stromal sarcoma. These are not targetable alterations, but are hugely critical to inform the treatment choice and confirm the diagnosis. A review by a group in Cambridge who conducted whole genome sequencing on a number of their diagnoses resulted in a refinement of diagnosis in 37% of cases when whole genome sequencing was performed. Sequencing is also quite pivotal in terms of prognostication for patients and identifying prognostic biomarkers. For example, the PAX-FOXO1 fusion is a poor prognostic marker in young patients with rhabdomyosarcoma, and its identification may result in risk stratifying patients into a higher risk category and escalating their chemotherapy protocols. Similarly, in Ewing's sarcoma, we now know that this is really a family of tumours, and the recently identified chick-fused and B-core rearranged group within the Ewing's family tend to have poorer prognostic outcomes, which is important to know from early on. So identifying subgroups requires sequencing large numbers of cases and correlating genomics with clinical features. And given that these are rare tumours, it shows the importance of multinational effort when it comes to clinical trials, tumour banking, institutional-based clinical sequencing, and data sharing. So this is a large body of work performed by the group at MSK, who analysed over 2,000 sarcomas representing 45 pathological entities. The most common alterations were in cell cycle control. They identified that tumour mutational burden was low compared to other cancers, but again varied between subtypes. And this is quite an important resource to inform investigation and future markers of response in clinical trials. So just to focus on two precision oncology studies which are prospectively being conducted in sarcoma. So first, the multi-sarc study. This is a randomized phase 2-3 NGS-based trial being run by the French sarcoma group, including patients with advanced metastatic soft tissue sarcoma who are treatment naive and have adequate histological samples. Patients are randomized 1-to-1 to no NGS and standard of care versus NGS discussion at a molecular tumour board. If a targetable alteration is identified and patients are eligible for targeted treatment, they're then screened for a single-arm phase 2 study. If not, again, they go to standard of care follow-up. I suppose it's important to point out that NGS is not standard of care in all soft tissue sarcomas, and its utilisation is not universal. So the primary objective is assessment of feasibility of NGS in sarcoma, and also assessment of impact on survival, efficacy and safety of targeted treatment. So the final results of this trial are awaited, but preliminary results were presented at ESMO last year. At that time point, 439 patients were enrolled. 314 alterations were identified across 62 genes. We can see these genes here. Most of them are not typically considered druggable targets. But of the 47% of patients in the NGS arm, but 47% had at least one targetable alteration, and 36% of these received targeted agents based on NGS. So we'll await the final result and publication of this trial. Another group is the Sarcoma Accelerator Consortium. So this is a collaboration of institutions across the UK, Spain and Italy. One of their trials is the PANTHER-S study, precision medicine approaches for neoadjuvant therapy in high-risk sarcoma patients. So this is a tissue-based cohort study for patients undergoing either for patients who either go straight to surgery versus are those treated with neoadjuvant chemotherapy. It's a prospective study where tissue is collected at 2 separate time points. And essentially the aim is to compare those treated with neoadjuvant chemo versus those who didn't, and conduct a proteomic and genomic profiling on these specimens to help understand chemosensitivity and resistance, potentially identify novel biomarkers for future trial design, and potentially identify a calculator to predict the benefit of neoadjuvant chemotherapy in this setting. What about the role of liquid biopsy? So in comparison with other cancers like lung cancer, this is very much in its infancy. In sarcoma, it's more limited due to biological complexity, but there have been recent trials which have incorporated it into trial design, particularly in the area of GIST, to help identify mechanisms of resistance to subsequent lines of therapy. The challenges are that we need a high disease burden to identify ctDNA. Sarcomas tend to have deep anatomical sites with less shedding into the bloodstream. And as we've mentioned, there are a lack of universal driver mutations in many sarcomas, but despite this, progress is being made. So out of all the specific subtypes we could focus on, I've narrowed it down to 3 subtypes. So one, a more common subtype, less common, and then an ultra rare subtype. And it's hard not to discuss GIST when we're talking about precision oncology, as really it is one of the perfect examples. Up until the year 2000, patients with GIST were being treated with chemotherapy, which didn't work and caused toxicity. But we know that not all GISTs behave equally, and really mutational analysis is mandatory for these patients, as we want to identify the patients that we very much expect to respond to imatinib. We know that this includes KIT and PDGFRA patients, minus one exception. Most patients, the disease harbors exon 11 mutations in 60% of cases, followed by exon 9, where in some jurisdictions and guidelines a higher initial dose of imatinib is recommended. So imatinib really is the dominant player here. It's hard to see it ever being beaten out. Some patients displaying very prolonged response to treatment, years, sometimes decades, in exceptional responders. However, resistance will inevitably develop, and our options thereafter are really nowhere near as good. So sunitinib second line, regorafenib third line, ripretinib, which is FDA approved in the 4th line setting in the States, and EMA, it's not currently available in Ireland or the UK based on the Invictus trial, and unfortunately failed to demonstrate a benefit over sunitinib in the 2nd line setting in the INTRIGUE study, despite real world evidence showing it to be a much better tolerated therapy. And another important subset just to point out in this group, so the PDGFRA exon 18 D842V mutations, which show primary resistance to imatinib. So the Navigator trial investigated avapritinib in this group, a very active agent in this subset of patients, however, again, not yet approved, and did show some unusual toxicity with neurocognitive side effects. So just to give a brief focus on the so-called wild type GIST, so in this case, we need to know, are the tumors SDH deficient or SDH competent? SDH deficient patients with SDH deficient GISTs require referral for genetics assessment and germline testing, as it is associated with hereditary diseases, including the Carney's triad, Carney-Strattakis syndrome, and associated with paragangliomas. This is typically considered resistant to therapy in the metastatic setting. However, a novel agent, olverembatinib, has shown promising activity in this group, and the phase 1 studies were presented at ASCO last year. And then when you get a report saying that the tumor is SDH competent, what do we do then? So further sequencing will be helpful in these cases, as some of these patients' tumors harbor BRAF, NF1, and NTRK fusions. So synovial sarcoma then is a sarcoma associated with poor prognostic outcomes. The name is a misnomer. It doesn't originate in the synovium, but commonly originates in the extremities, can occur anywhere. And it has a classic genetic signature, the SS18 SSX chromosomal translocation. But this is not the target we'll be discussing. The target is MAGE-4 and precision immunotherapy or adoptive T-cell therapy with an agent called Afami-cel, which was investigated in the Spearhead-1 international phase 2 trial. So this included patients with advanced synovial sarcoma and myxoid round cell liposarcoma. Not all patients were eligible, so patients needed to have a specific HLA type, HLA-A02, and the tumours needed to express the MAGE-A4 antigen. In this trial, patients were heavily pretreated and had unresectable or metastatic disease. The response rates were 39%, and in the response, responders, it was observed that they had very durable responses at 6 and 12 months. So this is a precision medicine approach and marked the first significant advancement in synovial sarcoma treatment in over a decade. And on the basis of this phase 2 trial, it has been FDA approved for the past year. So the first FDA approved T-cell therapy treating a rare sarcoma. And briefly, another target in synovial sarcoma is NY-ESO-1. This is a cancer testis antigen highly expressed in synovial sarcoma, being investigated in early phase focus on an ultra rare sarcoma, inflammatory myofibroblastic tumor, or IMT. This is a tumor more frequently seen in adolescents and on young adults. It has a predilection for the retroperitoneum and in some cases can behave like a high-grade sarcoma, behaving aggressively and metastasizing early. But it's a very interesting tumor from a molecular perspective, as 50 to 60% of IMTs harbour ALK fusions. Somewhat different to what we might see in lung cancer, less commonly observed EML4 ALK fusion, but appears to have different fusion partners. Following on from that, ROS1 alterations and NTRK, RET and PDGFR less commonly. So 2 clinical trials have demonstrated very good response rates in patients with ALK rearranged inflammatory myofibroblastic tumor, the phase 2 EORTC led CREATE trial. And there are many individual case reports of patients with ALK or ROS1 positive IMT responding to 2nd and 3rd generation ALK inhibitors. So this is just a summary slide of the other precision oncology studies in sarcoma subtypes showing promise in the last 25 years. So what's the take-home message? So obviously sarcomas are complex and a precise diagnosis is key, and NGS has certainly helped in this regard. NGS is probably not useful or feasible in all cases, but adopting NGS as a complementary approach in cases with complex genomics and those with limited treatment options has the potential to deliver precision medicine to a subgroup of patients with novel therapies. Thanks very much.
Thank you, Caitriona. Thank you so much. In the interest of time, we'll just get going to Professor Grainne O'Kane. For the attendees, please don't be shy. There is a Q&A box and our speakers are more than happy to answer any you may have. You don't have to, you can feel free to add your questions to that box. Thank you, Grainne.
You can see my screen okay, Dervla?
Yes, I can. Thank you.
Oh God, it's going ahead. Okay, these are my disclosures. So I'm going to give you a very high-level overview of where we've come in precision oncology in both biliary tract cancers and pancreatic cancers in the next 15 minutes. And I'm going to start with this slide, which is really your take-home message as well. And this is what I strongly believe, is that molecular profiling and certainly NGS testing should be performed in all patients with both biliary tract cancers and pancreatic cancers. And this information provides not just predictive information for therapeutics, but also prognostic information that I'm going to explain. So looking first at cholangiocarcinomas, what's interesting is P53 inactivating mutations and other tumor suppressor genes such as CDKN2A deletions are common to both cholangiocarcinomas and to pancreatic cancers. But when we think first of the anatomical subsets of biliary tract cancers and intrahepatic cholangiocarcinomas, what we really have to look for are a number of targets, including FGFR2 alterations. These include fusions, mutations, and these very specific in-frame deletions in the extracellular domain, which are uncommon but highly targetable. Also, IDH1 mutations and different BRAF alterations, of which V600E is most common. And then below that, we have a number of agnostic targets that I like to think about. So germline mutations, these actually occur in about 5% of cholangiocarcinomas. And I predict in the future that these will be reflexly tested as we do for pancreatic cancer. Mismatch repair deficiency, and of course, the rare fusions such as NTRK fusions and NRG1 fusions we like to see. But as we move down the biliary tree from intrahepatic ducts to extrahepatic ducts, becoming from small duct to large duct, we see much more profiles synonymous with pancreatic cancer, so KRAS mutations, but also notably we see HER2 amplifications in these extrahepatic cholangiocarcinomas and also in gallbladder cancers, to the point where about 1 in 4 gallbladder cancers are thought to be HER2 amplified. This is a highly targetable gene when it's amplified and overexpressed, and so something that we should be looking for in all of our gallbladder cancers. And then when I think about pancreatic cancer, what I want to know upfront when a patient comes to me with pancreatic cancer is what their germline status is, what their mismatch repair status is, and then whether they have a KRAS mutation or whether they don't. If they don't have a KRAS mutation, which occurs in about 10% of patients, you need to look really hard for alternate drivers such as fusions. So now thinking about cholangiocarcinoma on its own, and so I'm going to do this with a case because this is something we see quite a lot in Ireland, and Dervla will know this with her Cancer of Unknown primary programme. But this is a patient who's a 50-year-old female who presents to her family doctor for just a regular checkup and is found to have abnormal liver function tests, no past medical history. And then on workup is found to have this liver mass. Her endoscopy is normal, her CT chest is normal, and she has a CK7 positive adenocarcinoma. And what we see on the scan is some liver retraction. And what I want you to remember today is if you see a liver confined mass or even multiple lesions within the liver, you have a normal OGD and you don't see anything else outside the liver, this is cholangiocarcinoma almost all of the time. And so this particular patient goes on to have resection. It's a 7-centimeter mass, it's small duct, and that's important because when you have a small duct tumor, you're more likely to have these targetable alterations, moderately differentiated, and a local NGS panel is performed showing an IDH1 mutation. This is something I want you to remember also. So this was performed using a 50 gene panel. Interestingly, our guidelines actually suggest in patients at high risk for recurrence that we should be sequencing our cholangiocarcinoma patients early in preparation for systemic treatment at recurrence. This patient did go on to recur, and she recurred within 18 months of her resection. And this patient actually underwent a PET scan showing oligometastatic disease, had chemotherapy, and then had a re-resection of her liver metastasis. And what's really interesting when we did the whole genomic sequencing in this tumor is that we found the IDH1 mutation, but we also found an FGFR2 fusion and a BAP1 mutation. That's not that these were acquired at the metastatic setting, but that they were missed by the diagnostic in the first instance. And cholangiocarcinoma sequencing, you must look at the diagnostic that you're using. The FGFR2 fusions have over 70 partners, and I prefer that my cholangiocarcinoma patients have sequencing using a 500 gene panel optimized for fusion detection. So the FGFR2 fusion is important from the predictive standpoint, but I'm also very happy about this molecular profile for other reasons. And so this really nice joint publication by Memorial Sloan Kettering and Erasmus, if you just look to your right, shows independent prognostic impact of the co-occurring tumor suppressors such as CDKN2A and TP53. So if I don't have CDKN2A and TP53 mutations, I'm much more likely to be aggressive with these patients, as in this case where this patient actually underwent a re-resection for a recurrence of her original tumor. Of course, KRAS mutations are prognostic independently as well, but in the setting of a small duct IDH1 mutated FGFR2 fusion patient, we don't expect to have a co-occurring KRAS mutation. But of course, we now have an IDH1 mutation and an FGFR2 fusion, and these can co-occur in patients with intrahepatic cholangiocarcinoma. And intrahepatic cholangiocarcinoma really has become the new poster child for precision oncology. So really up until 5 years ago, we were using chemotherapy in the advanced setting and in the adjuvant setting. And just to note, Attica-1 will read at ESMO this year. But over the last 5 years, as you can see in the orange, we now have a number of targets that we do have to look for and a number of approvals. And just to the points Hazel made earlier, disappointingly, we don't have approvals or reimbursement in Ireland for many of these drugs. We do have for pemigatinib. If you look to the top right, of course, immunotherapy and immune checkpoint inhibitors with TOPAZ-1 is now our standard of care in the first-line setting. This has not yet been reimbursed in Ireland, despite receiving EMA approval in early 2023, but certainly we hope to have this soon. And when we look at these targets in intrahepatic cholangiocarcinoma, I'm not going to go through these in details for the sake of time, but I want to just draw your attention to the overall response rate. So of course, ivosidenib targeting IDH1 mutations is primarily cytostatic. So we see response rates of about 2%. But for FGFR2 fusions, BRAF mutations and HER2 amplification, we're seeing response rates up to about 40 to 50% in patients. Progression-free survival around 5 to 9 months. But if you look to the right, you're seeing really impressive median overall survivals in these patients who are pre-treated. Of course, we have our other alterations that are more agnostic and new kids on the block that are coming rapidly in terms of MDM2 amplification, MTAP deletions, and KRAS mutations. I just want to draw your attention to two important papers published in the Lancet Regional Health this year. There's Irish co-authors on this looking at disparities. I'm very passionate about the disparities for cholangiocarcinoma patients. These should all be on a single pathway and discussed at an MDT, and that MDT should have a molecular tumour board. And we don't yet have this in Ireland, but hopefully very soon. And so then thinking about pancreatic cancer. And so, you know, everyone has been very nihilistic about pancreatic cancer over the years. We know that this is a systemic disease driven by KRAS mutations in 90%. KRAS G12D does associate with the worst overall survival, particularly in the resected setting. But what we now know about pancreatic cancer is that the genomics, the DNA-based profiling is important, but this actually exists in different RNA-based subtypes along the classical to basal-like continuum. And this certainly has impact on outcomes and prognosis. And I just want to give a shout out to Rona McLaughlin's work presented at ASCO this year, really noting in the neoadjuvant setting that patients with basal-like pancreatic cancers really don't benefit from neoadjuvant chemotherapy and probably not surgery and do quite poorly. But again, I like to think about these patients as in their germline status, their KRAS mutation status, and I do think in the future we will be looking at classical and basal-like subtyping, particularly in KRAS wild-type pancreatic cancer. So if you get any genomic profile from pancreas cancer that shows that there's no documented mutations that I've seen on some of our reports, then they have missed something. It's not that there's not something there. And so in RAS wild-type patients, you're looking for alternate drivers. And most commonly, these are these BRAF alterations. So not V600E, but these small in-frame deletions that are highly targetable, although there is heterogeneity within these, but certainly can be targeted with MEK inhibitors alone or with combination BRAF and MEK, as published here in this JCO Precision Oncology paper. But also you're really looking for these rare fusions. And this publication in the New England Journal of Medicine this year on zenocutuzumab really highlights the benefits of this as a real precision oncology approach for patients. This is a needle in a haystack. But when you find a patient with an NRG1 fusion in pre-treated pancreas cancer patients, this drug provides an overall response rate of 42% and a median progression-free survival of 9.2 months. And that is something that we do not see with any chemotherapy in second line. This article and this figure was really published about 3 years ago with Professor Maeve Lowry, again, highlighting the different molecular subsets within pancreatic cancer. And it's amazing. Already, this is outdated. And so thinking about where we are moving in terms of KRAS, so again, to what Hazel has spoken about, in terms of KRAS G12C, this represents only 1% of pancreatic cancers. You do get some very nice responses from adagrasib, but really the field is moving very quickly. And so we are looking at mutation-selective inhibitors, looking at specific mutant alleles, pan-KRAS inhibitors or pan-RAS inhibitors, which are really causing most news headlines, specifically with daraxonrasib, the RMC-6236 drug from RevMed, with this really nice mechanism of action forming this type of molecular glue, targeting the RAS-on pathway. And what we see as RevMed update us regularly, but this presented at GI ASCO this year in, again, pre-treated patients with pancreatic cancer. We're seeing response rates of 36% with this drug, median progression-free survival of 8.8 months. And really, when you think about chemotherapy in the second line, you're looking at progression-free survivals of about 3 to 4 months, and median overall survivals that are extremely impressive. And I appreciate this is a phase 2 study, but very promising. And if you look to the right and the bottom, you will see that we are seeing really nice reductions in the VAF of the RAS mutations when we utilize ctDNA. And just to highlight the importance of this, so we have the RASolute trial that's looking at this in second line that has just got waiting lists all over the world. We do have the MoonRay study at the phase 1 unit here in Dublin with Austin, which is fantastic. But already these RAS inhibitors are moving into first line. So this is a trial that's ongoing at Memorial Sloan Kettering at the bottom left, where they're already beginning to combine this drug with chemotherapy regimens. So this is just an overview of where we're at in terms of pancreas cancer, just to really highlight that we have made huge progress. This is not a single disease. Homologous recombination deficient pancreas cancer can be treated with PARP inhibitor maintenance, but more likely in the future, we're going to see combinations with immune checkpoint inhibitors. Mismatch repair deficient pancreas cancer, again, immune checkpoint inhibitors can be used, perhaps not getting the same responses, not unexpectedly, as other tumors. RAS wild type and RAS mutations we've discussed. But again, thinking about where we're moving and RNA-based subtypes, I think this is going to dominate a lot of the future studies and selection for upfront strategies very soon. And we, of course, have new targets coming. HER2 amplification doesn't occur very often in pancreas cancer. And if there's a co-occurring KRAS mutation, it's unlikely that you're going to get activity from any of our HER2 targeted therapies. But MTAP deletions are very promising, and we're hoping to have some trials in that very soon here in Ireland. So again, just to finish on our whistle-stop tour, I strongly believe that both of these cancers, biliary tract cancers, which is really a group of different diseases, and pancreatic cancer are molecularly driven tumors, and they should be all having profiling as early as possible, recognizing we don't all have access to that. The molecular profiling really does provide prognostic and predictive information, and I think it's a very exciting time for anybody and encourage all the trainees to go into HPV oncology, because I do think we're making huge progress in this area.
Thank you so much, Grainne. And just to complete, and just a credit to all the speakers for keeping to time, we have the final 15 minutes allocated to breast cancer. Professor Michaela Higgins from St. Vincent's University Hospital will speak.
Thank you. Thanks a million, Dervla, and to all the organisers there. Claire is going to kindly rotate slides for me because I'm having some difficulties at my end. So there you'll see my disclosures. And I don't like to brag, but you can go on to the next slide. Really, despite what everybody has said this hour, breast cancer has been the poster child for precision oncology for decades. And that's because we've been targeting the estrogen receptor commonly expressed on about 3/4 of breast cancers for decades. So we've been on to a good thing. And this year and in the decade since, we're just working on that platform and using precision oncology molecular testing in our absolute everyday practice and in our decision making for all of our patients. We still classify breast cancers largely by whether or not they express the hormone receptors, which we can manipulate very effectively therapeutically. Some of our breast cancers have no receptors on them, and they tend to be much more aggressive and require chemotherapy or other therapies nowadays. And about 20% will overexpress a thing called HER2, and we've been targeting that for some time as well. So you can go on to the next slide. What I thought I would do today is really pick a bird's eye view of about 5 ways I'm using precision medicine in management of breast cancer patients currently. So I'm going to chat a little bit about HER2 testing, talk about some of the genomic decision aids available to help us decide for early breast cancer patients who needs adjuvant chemotherapy and perhaps who does not. Wanted to chat a little bit about germline BRCA testing, and then about somatic next generation sequencing that we're currently using for management of breast cancer patients, and a little bit about potential utility of ctDNA towards the end. Next slide, please, there, Claire. So you can keep going. It used to be very simple. We have a normal cell, and we used to look at how much of the human epidermal growth factor receptor 2 was present on the cell membrane. So there's a receptor that we can look for by easy protein expression via immunohistochemistry, or we can look at the nucleus to see how many copies of the gene are available. And as you can see, the cell on the right just has too much gene and too much receptors. Next slide, please. So there are, in fact, numerous intricacies to how to do this, and I'm aware you probably are a far more educated and specialist audience in this area. But loosely speaking, for the oncologist among us, obviously immunohistochemistry, where you stain the membrane and just describe relative degrees of brownness, can be graded from 1 to 3. If it's 3, it's positive. If it's 1 or 0, it's negative. If it's 2, it's in between. Fairly simple. But the immunohistochemistry can be a lot more, the in situ hybridization gets a bit more complex, where you're counting multiple cells and looking at the ratio of nucleus to HER2 expression. And there, of course, are gray areas, cells with these in-between numbers, in which case we often task our pathologists with going back and counting more cells or looking for an additional specimen to retest it. We can go on to the next slide there, Claire. So we have learned that if you target the HER2 positivity of cells that are considered HER2 overexpressing or amplified in breast cancer, it can actually transform prognosis. This was a huge breakthrough that started in about 2005, where we learned that by adding trastuzumab, which was a HER2 targeting monoclonal antibody, if we added that to chemotherapy for patients who had had early breast cancer removed surgically, we halved the likelihood of their cancer coming back. So that was sort of a jaw-dropping, fabulously positive result, that adding in something that targets the HER2 for HER2 positive early breast cancer transformed and halved cancer recurrence rates. In the decade after that, we learned about all different ways to do that even better than with single agent trastuzumab. So for example, if you add a drug called pertuzumab to the trastuzumab and the chemotherapy, you further improved care for both metastatic and early breast cancer. And over the last couple of years, there's been tons more HER2 targeting medicines made available, not all of them in Ireland yet, but multiple around the world, both oral kinase tablets available and more intravenous monoclonal antibodies and subcutaneous formulations of them. In 2021 and in the years since, we're finding that drug antibody conjugates, such as trastuzumab deruxtecan, are the latest game changers in the management of HER2 positive breast cancer. And we've seen response rates with that drug that we have never seen before, in the order of 60 or 70%. So nearly everybody with HER2 positive breast cancer will get a response to trastuzumab deruxtecan. But it's getting even more complicated. So it was relatively easy when you were either HER2 positive or HER2 negative. But now we're looking at the HER2 low population, these people who have a little bit of HER2 staining but wouldn't have been called positive before, but whose in situ hybridization is definitely negative. And it turns out that if you classify patients by sort of expanding on this gray area and the HER2 low population, you're going to capture about 55% of all breast cancers. And a lot of them will be hormone receptor positive, so ER positive patients, about 80% of them will also be HER2 low, and about 20% of triple negative breast cancers. Next slide. And so knowing that we have a drug that's really good for the HER2 positives and seemed to have what was called bystander effect on other cell types in the area, we've now examined the efficacy of that drug in these HER2 low populations. And that's what you're seeing here in the Destiny 4 trial, which took patients with HER2 low breast cancer who'd already had several lines of treatment for their metastatic disease, and randomized them to either current standard of care, which at the time was chemotherapy, or Enhertu, which is trastuzumab deruxtecan. And you can see in the next slide that it did indeed prove to be quite effective. Now, T-DXd is not as good in HER2 low disease as it is in HER2 positive disease. They had the lovely 60-70% response rates. Here the response rates were much lower, but still significantly meaningful. So the progression-free survival doubled from about 5 to 10 months, and the median overall survival increased significantly by about 7 months. And I suppose what's important to remember is these patients had usually exhausted hormone blocking treatment, which works well for the majority of them up front. But when you get into third, fourth line of treatment, actually the response rates of standard chemo are incredibly low. So having another effective treatment line has become actually a new standard of care, which happily has been reimbursed in Ireland only since July of this summer. Next slide. Wanted to talk about Oncotype DX. There are a number of genomic platforms, softwares available that can be used for risk profiling in early breast cancer, but this is the only one that's paid for and reimbursed in Ireland, and really it's the gold standard globally. So it is a 21 gene assay. It works on fresh RNA extracted from FFPE tissue breast tumors. And what it does is produces a gene expression profile dependent on levels of expression of 21 genes within your tumour cell. So that's 16 cancer genes relating to proliferation and those traditional receptors, really ER, PR and HER2, and then a couple of reference or control genes. And for every tumour they receive at Oncotype, they chew it up and spit out a gene recurrence score, which is a scale from 0 to 100. And what it very helpfully tells me is what is the likelihood of this person experiencing a distant recurrence? And what would the impact of giving that person chemotherapy be over and above what they're getting from hormone blocking therapy alone? I should have said that this assay is only approved and validated among women with hormone receptor positive disease that has been fully resected. We'll go to the next slide. So when I meet a patient, when I am wondering what she's had her surgery now, she hopefully is cured from her cancer, but we know there's a risk of recurrence. I'm going to give her hormone blocking therapy to reduce that risk. And I'm wondering, do I need to give her chemotherapy? And the Oncotype recurrence risk score tells me what's her estimated risk of distant recurrence if I just give her the hormone blocking therapy with no chemo. And if I give her chemotherapy, does she get further bang for her buck? Two really big studies have helped us learn how to use this. The Taylor-X study, first of all, showed that for women who did not have cancer in the lymph nodes underneath the arm and were postmenopausal, if they had an Oncotype test score of 25 or under, they'd absolutely no benefit to chemotherapy. So it's brilliant to say, listen, you have a low risk of cancer recurrence, never zero, and I choose my words very carefully. You have a low risk of chemotherapy. We know that taking hormone blocking treatment will help, but even if I give you chemotherapy, it will not further reduce that risk. So we're able to save the taxpayer the cost of giving that patient chemotherapy, and we're certainly able to save the patient a lot of time, the stress and toxicity of chemotherapy. For women who are aged 50 or younger and likely premenopausal, there is a very small benefit to chemotherapy if they have a score between 16 and 25. So that's a slight nuance and leads to a slightly longer conversation there. And I do still consider chemotherapy for that younger age group. The RxPonder trial then looked at women who had positive lymph nodes under the arm. And again, fabulously for the older postmenopausal women with early breast cancer, even with positive nodes, if they had a low Oncotype recurrence score, you can safely say chemotherapy would not benefit them and move on. For premenopausal women, there was still a benefit seen. So we do discuss the pros and cons of chemotherapy regardless of Oncotype in that group. We can go on to the next slide there, Claire. This is a look at the type of form result I get. You'll see on the left in the orange circle, there's their total score. And then it tells me what their estimated distant recurrence risk is on hormone blocking treatment alone there in the middle, and what the absolute benefit from chemotherapy would be. So you can see for that lady who has no negative tumour, there is no meaningful benefit to chemotherapy, and we wouldn't need to discuss it with her unless she was very young. In that case, well, even if she's very young, there's no benefit to chemotherapy for the less than 50. But say if she'd come out with a 21 to 25 score and was young, I'd be considering chemotherapy. All right, we can move on then. I wanted to chat a little bit about germline testing for inherited breast cancer variants. As we know, probably about 9% of breast cancers are related to an inherited breast cancer gene. Traditionally, we've sent them all to St. James's or to Crumlin for formal genetic counselling, but the demand for services has hugely risen, and to be honest, the waiting list there is just not sustainable, although it is the traditional way to get pre and post test genetic counselling and cascade testing for the family. Next slide. We are lucky to have some mainstream available in Ireland now in some satellite sites, and this is where the medical oncologists themselves can assess the risk, offer quite brief counselling, and send directly a gene panel test from their medical oncology clinic if there is a greater than 10% estimated likelihood of detecting a pathogenic variant. This has been really helpful for us and has helped cut down the waiting list, particularly for neoadjuvant young breast cancer patients. We can get their results in time for them to do their surgical planning. If we do detect a mutation and the family would benefit from counselling and cascade testing, they are referred back into the hub site, usually St. James's or sometimes Crumlin. For all breast cancer patients who might be in a position to benefit from PARP inhibitor targeted therapy, we're also sending the BRCA, just BRCA1 and 2, not a full gene panel, but just BRCA testing directly from the clinic where it would inform therapy, which has been a big advance in the last few years. Keep moving there, Claire. And I just wanted to talk about what I do when I see a patient who has relapsed with her breast cancer or has metastatic disease. Always re-biopsy the tumour, because sometimes the markers ERPR and HER2 can change, as you see there. And that's when I would also send away the BRCA test so that I can see if she's eligible for a PARP inhibitor. Next slide, please, Claire. And I consider whether or not to do next-gen sequencing on that patient. So here's where we often send for a thing called Oncomine. It's a multi-gene platform, and I am looking just for what for me are druggable mutations. So for breast cancer, we're looking for an alteration in the PI3 kinase pathway. That could be in PIK3CA or AKT, because we do have access to a PI3 kinase inhibitor on a managed access program in Ireland. So PIK3CA mutations are found in about 45% of ER-positive breast cancer, and unfortunately usually speak to a bit of treatment or relative endocrine refractoriness. It's a pathway that becomes activated and the tumours tend to become resistant to hormonal therapies. And it's there probably from the beginning. It's quite a driver mutation. So we look for that because I know I have a PI3 kinase inhibitor. And in so doing, if I send them for Oncomine, I might also find an ESR1 mutation. Now, the difference here is that an ESR1 mutation is usually not in the primary tumour. That is a mutation that evolves or develops over time, usually in the setting of endocrine therapy, and usually results in endocrine therapy resistance. It can develop in about 40% of ER-positive breast cancers, and there are ESR1 inhibitors available, not quite yet in Ireland, but we'll discuss those a little bit further because they're coming down the pike and we've had trials with those in our centres. Next slide. And that's just the PI3 kinase inhibitor, and in red I have the drugs that are available in Ireland. There's a very old-fashioned mTOR inhibitor, everolimus, which I have better drugs for, and alpelisib, which is what we would call a first-generation or non-selective PI3 kinase inhibitor, which does work in PIK3CA mutant breast cancer, but it's quite toxic and causes a lot of hyperglycemia, nausea, and rashes. Next slide. I'm just coming up to my 15 minutes. I'm two more slides. Well, maybe 3. ctDNA and breast cancer. In a nutshell, I know you've heard about it from other speakers this afternoon. We know that it is prognostic. That means that if when detected or when you capture it rising in a patient who has breast cancer, it does correlate with poorer clinical outcome. If you can find it in a woman who has finished neoadjuvant treatment for her cancer and it's still there, she has a poorer prognosis than someone in whom it has become undetectable. If 2 patients have had surgery for their cancer and one of them still has detectable ctDNA after her surgery, she is going to have a poorer clinical outcome. And if your ctDNA rises or becomes detectable during treatment for advanced disease, we know that that speaks to a poorer clinical outcome. What is a lot less clear is whether detecting volume of ctDNA or particular genetic mutations in the ctDNA, what's less clear is whether those results can be used to predict response to treatment. I was just going to discuss one study that demonstrates that a little bit. You can move on, Claire. So this was chosen to be presented at the plenary session in ASCO. You can move ahead. It is a drug, the SERENA-6 trial looked at the use of camizestrant, which happens to be an ESR1 mutation inhibitor. They took patients with metastatic disease who were already on first-line treatment, which would be an endocrine therapy and a CDK4/6 inhibitor, standard of care first-line treatment for ER-positive metastatic breast cancer. And what they cleverly did was every 2 to 3 months, they took a blood sample from those patients, and when or if an ESR1 mutation became detectable in their ctDNA, half the patients were given an ESR1 inhibitor at that time, and half of them just continued on their standard therapy as we would usually until their scans or clinical progression showed definite progression and they moved to the next line of therapy. So next slide, please, Claire. I've explained what they did in the study. You can go to the next slide. It turned out that if you changed to the ESR1 inhibitor when the ESR1 mutation became detectable, it improved your progression-free survival significantly over patients who stayed on the standard treatment until such time as their scans showed outright progression. Next slide. Now, there are definitely a few gripes with that study design, and I don't think I'd have chosen it for the plenary session. However, this is the first time really we have validated a molecularly guided early intervention strategy in advanced breast cancer. So it was definitely good to see that changing therapy based on a ctDNA result improved outcome for patients. I don't think it quite shows yet that ctDNA should be used in this way, or indeed that camizestrant is the drug of choice for patients with the ESR1 mutation. So I would say it's not quite ready for trial design, but I do think this was a very interesting study that we can learn from, and was really the first time we've seen ctDNA used in a predictive setting in advanced breast cancer. So next slide. In summary, I just wanted to say that HER2 testing has become a lot more nuanced, and we have much more wider applications for it than ever before. So stay friendly with your pathologist and your pathology scientist. Genomic decision aids in breast cancer are saving us money and patients' toxicity day after day. Mainstreaming is the way to go for genetic testing in breast cancer. And I think next-gen sequencing is going to increasingly guide ongoing precision oncology for breast cancer patients. And I'd just love to be using ctDNA, but we're just not quite there yet. Happy to take questions on that.
Thank you so much, Michaela. I mean, I must say, like, the last hour has just been an incredible supercharged boost of oncology, and really interesting to see how the different cancers have been developing their NGS. Happy to take any questions if anyone wants a question, if anyone wants to come on and speak a question. There's none in the Q&A box. And just to say thank you to the speakers. Oh, there is one actually regarding a quick clarification in the context of BRCA wild type. So versus what BRCA wild type versus BRCA negative patients, would the eligibility or recommendation for prophylactic mastectomy differ, or any treatment? I'm wondering whether the terminology affects how we interpret hereditary risk, and that's from Wei Yan, a clinical data coordinator in RCSI Beaumont. So I don't know who wants to take that.
It certainly does. If you are, they also take into account your family history. So if a person has a pathogenic variant detected in BRCA1 or 2, we do discuss prophylactic contralateral mastectomy to reduce their lifetime risk of breast cancer. Traditionally, if they have not been found to have a hereditary breast cancer genetic mutation, we do not recommend prophylactic surgery. However, there are cases where the family history is extremely striking, and we have not been able to pinpoint a particularly causative pathogenic variant in the germline analysis. And rarely we might even consider prophylactic surgery in someone who's a very strong family history in the absence of a documented genetic alteration. But in general, we have to isolate or find a pathogenic variant before we would recommend prophylactic surgery for both breasts and ovaries.
Thank you so much, Michaela. A quick, as I said, thanks to our speakers, an amazing all-female lineup of absolute foremost experts in Ireland from a variety of different hospitals. And I thought Michaela was going to start a fight there between who exactly was the poster child of precision oncology. But and a thanks to Claire Birmingham, who's the Molecular Tumour Board coordinator, does an incredible job with the National Molecular Tumour Board, and also arranges these educational sessions. So thanks everybody, and looking forward to the next one.